Hey, so thank you very much. Two very important talks. I'm going to ask our two speakers to come back to the stage for the panel discussion. We've got about 15 minutes or so for that. Two very important issues that bother clinicians intensely in clinical practice, so I'm expecting there'll be lots of questions.
I'm not sure. Yeah, it's working. So thank you very much for the outstanding lectures. So I have a couple of questions for Keyur and one for Dr. El-Serrag. So Keyur, the first question would be, so in patients, it's true that it's difficult to predict regression, after treatment, but generally in clinical practice, we see two different kind of dynamics. So there are patients where you see that liver stiffness stays continually high, and that there is no question about that. In those where you start seeing a decline in liver stiffness, after a few years, would you actually do a liver biopsy with regard instead of continuing HCC screening? I know there are no guidelines in this sense. Actually, guidelines recommend to continue the ongoing screening, but in those with persistently normal liver stiffness after 3 or 4 years from post-SVR, would you consider actually do a liver biopsy instead?
That's a great question, Giada. So, not that I like anecdotes, but I've had patients at my previous center who were cirrhotic, got cured, and then a couple of years later tried to apply for life insurances and couldn't get it because they were cirrhotic. And they insisted that I did another liver biopsy on them to show the insurance company that they don't have cirrhosis. So, no, I think that's important. I think one of the mistakes we made is we do FibroScans on a more regular basis than is needed without any corresponding fibrosis staging by biopsy. But I think after a few years where you have persistent declines and there are no, and the caution I would place here is also if they've got no features of metabolic syndrome or other behavioral risks, whether you call them non-cirrhotics, I think it's at this stage, it wouldn't be unreasonable to offer them a biopsy to see if they've regressed to a lower stage. But I think, again, individualized, take into account, as I mentioned, metabolic factors, alcohol, all these type of things. Again, there's I don't think you'll see guidelines or recommendations anytime soon. I'm not sure.
The other question I would have for you, actually, Keyur, is that so the fact that we have to do a non-invasive test for fibrosis in every patient is recommended by the guidelines. The problem is that I think now that the treatment for hepatitis C will start widespreading also to secondary and primary setting care, not everyone will have actually a fibrosis staging before the treatment. For example, in Quebec, AST is not actually widely available outside academic settings, and I always get a question from the gastroenterologist, I cannot get to the AST. So in those patients where you don't have, unfortunately, we will see more and more, you don't have a staging of fibrosis pre-treatment. What we can do after treatment if we don't have a pre-treatment stage?
Again, a great question. Same in Ontario. We don't have easy access to AST for non-GI hepatologists. But I still, being old-fashioned, I still would love to. I'd like to see something for fibrosis stage before you embark on treatment, because the reason is, for reasons I just mentioned, I post SVR, I don't know what a safe threshold is for FibroScan or any of these tests. All I know is if the lower the number, the better. Then that's where your clinical demographics and your impression really comes in. A young person is less likely than take into account the traditional factors we used to use. Age, alcohol consumption, male gender, all these type of things, right? So, again, I would say you can do these tests afterwards if they're available, if they're low and they fit the clinical picture, then you can reassure yourself. But again, it's not clear cut. I'd like, before you embark on treatment, you would still like to see some fibrosis staging.
I just have one response question. Sorry for Dr. El-Serrag. I was very took from the from the alpha fetoprotein. So where you mentioned about the alpha fetoprotein for the residual risk of hepatocellular carcinoma, I'm interested in knowing your opinion in general on the alpha fetoprotein as for the screening of hepatocellular carcinoma. As in the last double SLD postgraduate course, there was a rehearsal of the alpha fetoprotein. So I would like to hear about your opinion. Sorry.
Yes, that's working. Fantastic. So the question is about alpha-fetoprotein and its role in surveillance for hepatocellular carcinoma. I recommend the use of alpha-fetoprotein, but not alone, combined with imaging. And the reason is there's a small but real incremental yield of having alpha-fetoprotein on top of an ultrasound. So I do that. A comment to your previous thing, the fact that it happens, I find it stunning. So anyone who read a textbook, no one reads textbook nowadays, but when you used to read textbooks, cirrhosis was defined as this irreversible condition characterized by blah, 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 blah. So the fact that it actually melts, I thought it would be heresy. But I'm seeing people with liver biopsy-proven cirrhosis who are now 3 years after a cure don't have anything. So it is happening, and I think my short answer to what you said is, short of a liver biopsy, I do 2 non-invasives, and in our place we do MR elastography. So if I have 2 things that are showing F1, I probably tell them it's over. It's good.
Yeah.
Hi, I have a couple of questions for Keir. So I found it interesting that you'd mentioned that the APRI was no longer useful or wasn't found to be useful in the tenofovir registration trials. I assume that's because they had improvement in portal hypertension and their platelets improved. Do you know if any of those biopsies, did they actually do like HVBG, like transjugular biopsies and check for improvement in portal hypertension? Were they all just percutaneous?
No, I think they were percutaneous. This was registration trials
Yeah.
for 102, 103 TDF. And it's compared to entecavir, not entecavir, to adefovir. So I think these are well-compensated patients, percutaneous biopsies, no HVPG measurements. The point I was trying to make is we use these tests, but again, if you're trying to correlate them with changes in actual fibrosis, particularly even good changes from cirrhosis to non-cirrhotic changes, they just do not work that well. They weren't designed that way. There are probably better things out there, but these tests were not designed to reflect changes in fibrosis.
And just one quick question, if you can, in terms of the shear wave versus the FibroScan, and you're talking about mechanical versus acoustic, what does that actually mean? In terms
For the practicing clinician, there's no dramatic differences. The difference is who does the tests. None of us outside European centers who train their hepatologists in ultrasonography, we are not trained in ultrasonography. The advantages of the shear wave, real-time elastography, ElastoPQ, and all the other tests are they offer you a B-mode image. The FibroScan, as you know, just offers an M-mode image and gives you a stiffness value, and you have a limited region you can look at. The others allow you to explore a wider region, right lobe, left lobe, etc. In terms of splitting the differences between which one's better, well, obviously FibroScan's been extremely well validated, available since 2005. Lots of studies, like FibroTest, lots of studies, and that's what we have to compare to. But nuances aside, you get the same ideas. But do not compare stiffness values across different methods. We had a patient the other week who thought he had an MR elastography, which was 5, and his FibroScan was 20. So he thought, oh, this is great, I'm cured. He broke his fast and his diet and went and had a week of like fast food, thinking he was much better. But so there are, you must if you use these different methods, reassure your patients that that the values do not, the stiffness values get a different depending on different modalities. That's important.
So we have time for two last quick questions. We're going to bounce back and forth. And so far I can hear it's complicated coming through in the
Yes.
Okay, so I'll try to keep my question simple, but since Dr. El-Serrag's pointing everyone to me for the complicated questions, I'm going to throw it back to you and say, in the people who have, do you really think if they have regression even on a biopsy, that's enough to tell someone they don't need surveillance? Because I guess my question is the carcinogenic factor the fibrosis, or is it other architectural changes that happen in the liver? And whether you use non-invasive tools or you use a biopsy to define it.
So excellent question, and the answer is I don't know. My guess is yes, but given that I've shown those immunological and non necessarily mechanical things, there's a reason to think that it possibly could persist. What I was alluding to is from pure practical purposes. I mean, we have a loaded clinic with people who are clearly cirrhotics, and the mid-levels come and say, do you really want to do an ultrasound every 6 months on this person with an F1? What are you going to do? But in my gut, they need to be studied to see if regression by conventional fibrosis factors really predicts drop in the risk. So, yeah.
I will also say the Italian study also looked at markers of fibrogenesis, smooth muscle actin, etc. And they found even post-SVR, 15 to 20% of patients on their repeat biopsy still had, despite SVR, still had evidence for ongoing fibrogenic activity, whether it's due to metabolic factors, etc. It's not Hep C, it was 4 years later.
So what I answer them is keep them for next year. Until next year.
We have better data. Thanks.
So we are running a little bit behind.
I think
on
this
time.
is an interesting question, though.
I love interesting questions, so you can ask it, and we get a very specific, committed, quick answer.
The answer may not be interesting.
It's for Dr. Patel, although I also have one in reserve for Dr. El-Sarrag. Dr. Patel, your talk was beautiful. And echoing Dr. El-Sarrag, indeed, 20 years ago, it was heresy to say that cirrhosis could regress. And indeed, 20 years ago, there was a great deal of resistance to that concept. But Medivir and Ishak and all of the generally accepted scoring systems were all designed before the concept of regression came. So do we not need a new scoring system which is purposely designed to embrace the concept of regression?
Yes, I agree with you totally. Again, with all these tests, none of them are, as I mentioned, set up to even assess regression. But there are markers of regression immunohistochemically, and these are important to ask our pathologists when we talk to them, whether these features are present. Also, we know that, cirrhosis, not these days when we treat patients with far more cirrhotic injury, if you like, decompensated disease, Child's B and C. Certainly in the Child's A, even though functionally the liver got better in terms of your serum markers, architecturally, the collagen matrix, the nodules were still there as well. So even some of the patients went from a stage 5, were called stage 3 by Medivir, Ishak 5, but they still had some, incomplete cirrhosis patterns still there. So again, I think you're right. We need some better staging systems for regression. But again, we don't do biopsies anymore for post-SVR patients.
Thank you.
That's great. Thank you very much. And thank you for your comments.